Tēnā koutou, tēnā toto, kina toto katoa. Thank you, Fiona, for the very kind introduction. And thank you to the Migraine Foundation, Aotearoa New Zealand, and the Neurological Foundation, as well as AbbVie, for making this particular event possible. It is for you, the patients, and we're here for you as well as physicians, although we wish there were more of us to be out there for you. Unlike the previous speakers, I am actually talking in front of my teacher, so it is a little bit more nerve-wracking for me, especially after the excellent talks that's been provided before. I've got the slightly more difficult position in terms of going what is available and what isn't available in New Zealand. How do we get to a stage of accessing things? And with what is available, what do we know about it? And should we go ahead with something like this? I want to meet my speaker. Hi. So I'm part of Palmerston North Hospital and affiliated with Otago and King's. These are my disclosures, of which some of the medications and therapeutics that we discuss are provided by some of these companies, apart from Medlink, which provides education. And when we talk about management, unfortunately, it sometimes starts off with you as the patient. And you would have heard a number of different things in terms of lifestyle management, and your GP would put kind of the onus a little bit on you. And I don't want you to think that that is where it's going to end. And a lot of you would know that that's not where it ends, because if that's where it ends, we wouldn't be having this particular talk, and we wouldn't have had all the research involved in it. But we do know that we can modulate a few things. We might not necessarily solve it all, but we might be able to modulate a few things through lifestyle management. For a few people, lifestyle management is all that is required in terms of getting adequate control, but it might not be the case for your particular situation. There have been some studies that are upon sleep. There have been research upon the biology of sleep and the neuropeptides that are involved in sleep and how that has an effect in migraine. We've seen studies on diet, and they're a little bit fraught because they all seem to be effective. We've seen studies on exercise as well, and you'll be asking yourself, how hard, how much, how long, what should I be doing? There's things on psychology, cognitive behavioral biofeedback work, as well as what about supplements? What else can I take that's not a pharmaceutical? I really do want to plug in the Australian New Zealand Headache Society. There is a website up there. There is information on there. I put this one out to every patient of mine to look at the self-care that you can look at. Now, this is only a small snippet of it. I'm not saying this is the thing to really focus upon. But they also have other really good resources as well. It is more Australian-centric, so finding physicians there is quite easy if you're in Australia, probably a little bit harder over here, and I'll go a little bit more about that a little bit later on. I think lifestyle is somewhat important, and I've just pointed to this particular paper, which is a bit hard to access if you don't have a subscription, by Nazia Kassan, which really does talk about the homeostatic processes. And Professor Goadsby has already spoken about how the hypothalamus is really a key neuro part of the brain that is involved in the processes that we experience, especially some of the premonitory type symptoms that he's already mentioned to you before. And a lot of people will say, I don't sleep as well, I'm feeling tired, I've had a change in what I want, I don't feel like eating, my thinking's not quite all together. And it's a combination of different symptoms that begin in the process. So when I'm talking about lifestyle management, what I'm saying is that this is a biofeedback loop. The hypothalamus has got some control. It gets told, yep, this is a good time to eat. Yep, this is a good time to go pee. And it's a good time to go to sleep. But if you start fiddling with that and you alter it, it is a little bit hard. It's working a little bit harder and it's doing other things at the same time. So having some sort of, stability can be helpful. It's not going to solve the problem necessarily, but having some stability would be helpful. Having some predictability would be important. When I talk to people about sleep and exercise, I talk to them a little bit more of the sense that this is a thing that's good for you. Sleep is generally good. Exercise is good, and it has lots of different health benefits, and having a healthy diet is good. But it's a change. It's still a change to you, and your brain might not like that change right now. It will hate that change. So any change could lead to a worse thing for a period of time before it kind of a little bit settles down. So if you decide that you're going to start doing couch to 5K or couch to 10K, if you're going to decide that now is a good time because hot and spicy is back at KFC, I'm just going to hit that before it goes, they will probably both, despite the fact that from a health perspective, they're very different. Obviously, one is frowned upon, and the other one's not so frowned upon. I won't say which, because my wife will comment about my health choices. It will lead to a change, and it will just take a little bit of time to kind of settle down, and that's a little bit about the kind of brain processes that are happening. Up on there will be a headache diary as well, and I really cannot stress how useful it is, not just to me all the way down the end, but your GP in terms of communicating to other people, to look at whether or not something is effective. You don't have to go into high detail. It could be just, I have a headache, I've taken some treatment, I took this treatment. It just gives us a little bit of an understanding about what's going on. We could go in the more archaic age and use paper, and I tend to use paper because it means I can look at multiple months at the same time. But you can also do be more a modern human and use an app or something like that, and those work well. Apps can sometimes be a little bit more fraught. It means I have to scroll and memorize things. Hopefully I can do that. Maybe your doctor's better with a photographic memory. But they're really helpful. And it's really helpful because if you do things like this, and I've just generated this, you can see that November was better than October. And you can do it by numbers, you can do it by mild, moderate, severe. And I've put X's just to say, hey, I've taken some pain relief. And I can flick down. And maybe you did an intervention. Maybe you did something at the end of October. And you go, well, was that good? Was that helpful? Did that lead to something useful? And if it didn't lead to something useful, it's either it's time to move on from this thing that you've tried because it doesn't work, or it's time to increase, let's say if it's a pharmaceutical, it's time to probably talk to my GP about increasing it, because there's no point being or doing something over and over again, waiting for it to have this effect when it's not. It's called insanity. Right, so let's go talk about a couple of things that you could possibly do. I'm going to focus first on the things that are not stuff that we do to you. So there's no surgeries in this. We're not going to stick something into you at the moment. I got a little bit interested into yoga because my wife became a yoga teacher in between her medical time while we had children. And I was working with Professor Goatsby at the time, and she looked at yoga as to whether or not that can be helpful. Now, a number of people will find that the right-hand image of that downward dog just horrible. Just no, why would you do that? You may think yourself. So there are some trials that are out there, some randomized controlled trials. The difficulty with studying yoga, as you probably have worked out, there's different types of yoga. There's yoga where you are what they call vinyasa or power yoga, and then there's the other ones which are a lot more relaxed, like yin yoga. So they're very different in terms of the physicality required for each one of them. And so the styles are different, your sequence is different. Unless you're doing Bikram where you're just going to be sweating the whole time and suffering, it's got to be different every single time. And because of that, it's really hard to study something that has variation without consistency. And which one is better? How do you define one sequence is better, one technique is better? But in general, there's an impression that this is not a bad thing. Can be quite helpful. And the most important thing is that there's actually no harm in doing it. You don't really hear people having serious outcomes unless they're going for a really long stretch and pop something they shouldn't have popped. But most of the time, this is no adverse effect. So it could be a useful thing to add on and be part. And again, exercise is a healthy thing, so not necessarily a bad idea. What about acupuncture? Again, very difficult to standardize the studies that are there. There are a number of studies out there, and it's very difficult because everyone does something slightly different. Because they're trying to work on what you're telling them. And one of the hard things is that what you're telling them may sound very vague and very different one day compared to another day, because we just don't have that kind of level of localization, as Professor Gosebert said, with the juror, in terms of this is the part, and so they go for that particular region. And they will go for that particular region, which will be different to another person, will have a feeling in another way. So they kind of adapt. It's a little bit hard to get that kind of standardization. But once again, the good news is that this is not harmful as well. And for a number of people, this can be quite helpful. There's some impression that it gives some short-term relief, although these trials aren't strong on that and doesn't have the evidence for it. And again, this could be something that you can add on if it works for you. If it speaks to you, that's the thing you're probably going to hear from me a little bit, especially with the non-pharmaceutical treatments. If it speaks to you, and if it works for you, and it's not harming you, and bear in mind some of these things cost money, but YouTube is free apart from your internet connection, then this is not a bad thing. It works for you. I'm happy to have that as part of your management. And anyone who says that they aren't probably it's not quite getting what needs to be done next. Now, this one I do have a little bit of caveat upon. There are a number of chiropractors out there who have practices, and there is practice out there specifically for headache management. The study quality, again, is a little bit fraught, and there's different things in terms of when you look up chiropractic care. There's spinal manipulation, and then there's cervical manipulation, which is your spine above from the neck upwards from the neck. And the difficulty is that, again, quality of the studies is just a little bit fraught to go, yep, that's a great idea. There's a thing called a meta-analysis where people kind of take in lots of data from different papers and different studies and try and see if they can match it up together and see how good the information that we have, and kind of collect them all to see if we can get a more concrete conclusion. And there's some impression that maybe this can be helpful. I personally have just one little issue with it, only because of my time at Hamilton Hospital, where I did meet an unfortunate young man, and this is not his scan on the right-hand side, who did suffer from a vertebral artery dissection. Obviously, the chiropractors wouldn't want you to be aware of it. I want you to be aware of it only in the sense that I don't like the idea of rapid manipulation of your neck by somebody else. You don't have the protective control of it. The neck, the cervical region has quite a big range of motion. You can go for almost a good 180 in most people, but areas like your thoracic or your abdomen, your chest, sorry, or your abdomen, your lumbar spine, they've got very limited range. So you've got a huge range, and the blood vessels actually sit around, surrounded by bone. And then there's a space, and there's more bone again. There have been case reports of people who've had vertebral artery dissections. What I'm trying to show you on the bottom right hand, which lights up, is a stroke. This is a way for us to identify a stroke on the scan. Quite rare. Am I saying don't see a chiropractor? No, I'm not saying that. Am I saying that you should avoid them? No, again, still not saying that. What I'm saying is that if it works for you, great. If they're going to manipulate your neck, okay. Gentle manipulation, not a problem. Stretching, not a problem. I'm more worried about the rapid manipulation side of things, and that's a case that hasn't left me when I was a junior doctor.
Dr. Chen, sorry, I work for the New Zealand Chiropractic Association.
Mm-hmm.
I would just like to point out that no New Zealand trained chiropractor would inappropriately manipulate the knee, but also all of the studies and cases for any of those dissection incidents have all happened overseas, and there has been no dissection injury ever occurring in New Zealand or by a New Zealand trained chiropractor.
Sure. I can't, for that particular case of a vertebral artery dissection by chiropractic care, I did not and cannot confirm because we didn't ask. That wasn't what was important. We were looking for a mechanism at that time. But I cannot confirm in any way, and I think that's fair enough, and there's a disclosure, that that person was a person that was trained with the accreditation that you've mentioned, but it was certainly done in New Zealand. And there has been, as you can see at the top there, a complaint before about an individual who had a vertebral artery dissection after chiropractic care. Again, I'm not specifically stating that any one chiropractor is or is not. I certainly do see patients who have had chiropractic care with rapid manipulation of their neck. And again, I cannot state to you because I did not ask, because it wasn't relevant to me whether they were or not. The important thing from my perspective was, are we being safe in terms of what is being done to them? Because as a patient, as a client, the number one thing is your safety, and number two is consent. And you can consent. You can say to me, well, if I give you a recommendation, no, I don't want that. That's not for me. You're going the wrong direction. And if I can't adapt to it, you shouldn't be seeing me. And I shouldn't be seeing you, really, as well, because we can't develop a therapeutic relationship. And what I'm saying is that as a patient, you should be feeling empowered that, yep, I think this might be useful for me. I want to give this a go. And you should feel the ability to do so. But you should also be able to say, hey, I'm not quite sure this thing is entirely safe. I have heard some things about it. Can we not do that, please? And I think in developing that therapeutic relationship, which I believe would be part of your code, is really important. But thank you for the comment. This is a little bit more gentle, down towards massage. If you can convince a partner to massage you, this is a good one to go for it. Because again, also safe. There are small studies that have shown some benefit. Again, same fraught problem of not being well powered. And again, like I said to you before, these are useful things to help with your experience of it. These are not pharmacological. These are things that you can access, and unfortunately, because of the difficulty of accessing medical care, which I will speak a little bit about in a moment, you kind of want to know, is this hard? Should I go down that line, and that's going to be possibly my answer? The evidence suggests that probably not, but there's not to say that this can't be helpful and help in terms of your journey and your experience of this, because this is from what I've heard from people, this is a journey and it takes a while. Cognitive behavioral therapies or biofeedback or different forms of managing pain through one's experience, because it is an experience. So it wasn't until I worked for Professor Goadsby that I really understood migraine biology in a family sense. I had the occasional headache, but it didn't really bother me. But I have family members who have what would be full-blown migraines. And I wouldn't have ever said that I would have had migraine. But then when I sat down one day, being a little bit grouchy to my children at the time, I realized I wasn't really feeling that hungry at the time. And I was like, oh, there's that migraine biology in my family coming out a little bit. And now I understand what that feeling is. I understand what how I should be able to manage it. Am I in a lot of pain at the moment? No, I wasn't at the time, but I can process that, and having a little bit of an understanding does actually can be quite helpful for some individuals, especially when it's combined, and certainly in the studies, with pharmaceuticals. They can actually improve together your headache burden in terms of how many attacks you may be experiencing, or how severe the experience is, or how you feel the experience as well. And so that can be quite useful as, again, combining as part. And all these bits, like I keep saying, take the bits that speak to you, because that's what's the important part. I'm no way stating that you should buy one of these products, or specifically those brands. But there is small studies in terms of supplements that are out there. I know a couple of my colleagues do like talking about the last one, which is Migradol. But if we can get the last one to work, there we go. There are small studies that show that these particular supplements can be helpful. They're not very strong studies, or one or two for each one of them at most. With coenzyme Q10, generally pretty well tolerated. You might get some jaw discomfort or bruxism that's out there. Magnesium diarrhea is a common one. For anyone who drinks Berocca, you'll know what Berocca P is, where you get that fluorescent yellow urine. You'll get the same thing with riboflavin as well. But these are generally pretty well tolerated, and they're also on that self-care for migraine sheet that we have in there. These doses are evidence-based doses, as in they've gone through clinical trials. There was one study that threw all three of them together, and that seemed to be positive, but there's no comparison study. There's no study to say that combination is better than one alone. So again, nothing wrong with taking the combination of riboflavin and magnesium together, but there's no study to say that's better than just magnesium alone or riboflavin alone from my readings. But I do know a number of my colleagues do find that it's probably the easier way of getting riboflavin, which is only really available that I can find from Chemist Warehouse or Bargain Chemist. I haven't found it in any one of the other health food shops. I do need to put in this warning, although I believe other people have given this warning already. So if you need to avert your eyes, this is the time now. And Professor Goseby has already brought forward chocolate, because that is probably the most common avoidable trigger, if you will, that I keep hearing from people. And I'm glad that I can say this to a lot of people, but I don't think this is from the evidence, this doesn't seem to be a trigger. There have been provocation studies where they took people who said chocolate is a trigger, and consistently is a trigger, and so they fed them chocolate, which is such a horrible thing to do to them. I have no idea what kind of chocolate it was. I mean, but they gave them chocolate, and they did diarrhea studies on them, and they were inconsistently triggered. But then they did some really horrible things, and I believe one of them was done in London, where they gave people chocolate or carob. And they did another one where they gave people chocolate and this kind of compound which was sweetened with artificial flavouring and was fat. They really stressed the amount of fat that was in it and the texture of this thing to be as close to chocolate as possible, and they were unable to demonstrate that chocolate triggered attacks more so than something else that was chocolate-like. Apparently they made it so it was that good that you couldn't tell the difference. And as has been mentioned by Professor Goseby, likely this thing is not really a trigger, but are you sugar craving already at that point in time? Going a little bit sideways from that, I have a colleague of mine who swore to me, absolutely swears to me, that cheap beer causes him to have his attacks. Not craft beer, cheap beer. And as long as he continues to drink craft beer, he's perfectly fine. He's a bit older now. He said this was just happening during when he was in his university age kind of days. back in med school. I suspect that one of two things has happened to him. He's gotten older and he's male. And other thing is that he's become a snob. Right. So we're going a little bit into the pharmaceuticals at the moment. The stuff that I'm really talking about, you kind of do need a prescription. So you should go, this is the point of time that you're going to have to see someone in the medical field, a GP or a pharmacist to attain these. And, there are triptans, and it's, I haven't got the slide up there, but I'm sure a number of the audience has seen the data that Dr. Imlich has produced in terms of who has had a triptan. We don't have many triptans. We have 2 triptans, and I'll show you them in a moment. They're available. There are oral and one injectable one. But then we kind of forget the other thing, because the triptans are mostly focused upon dealing with head pain. And in general, you can probably manage the other stuff as well, because it gets better when the pain gets better. But we still got the prodromal symptoms that might be still going on. And while we talk about premonitory prodromal symptoms as if they're kind of separate to this headache symptom, they actually all kind of overlap over time. And so you might still have nausea going on despite the headache is being done. So there are antiemetics or anti-sickness tablets to help with nausea. There's a bit of evidence to suggest that metoclopramide combined with things like paracetamol or ibuprofen and aspirin can be almost as good as a low-dose sumatriptan. So again, if you're nauseated as another symptom, I can't do much about light sensitivity, you can get an anti-sickness medication from your GP. And you should take the opportunity to ask, because not every GP remembers to do that, because they're like, oh, you've got head pain, let's deal with head pain. This slide could be a lot sadder. I've put up there mostly what we've got available. Red is bad, green is generally good. We have sumatriptan and rizatriptan orally, and the subcutaneous version of sumatriptan available, and they're all funded. But some of the there are actually about, if I remember correctly, 7 triptans, internationally, probably 9 triptans available. We've only got 2 here. And the thing about the triptans is that just because one doesn't work doesn't mean another won't work. We're all different, and these are all slightly different in themselves. And some people respond to one over another. I have put down the G-PANTs that are available, and as well as the what's known as the Ditan. We used to call Ditans, I believe. I think I've seen lots of presentations with Ditans. We've only got one available, and none of them are available in New Zealand. Rimegepant or Nurtec is available in Australia, and even under the PBS or the Pharmaceuticals Benefit Scheme over there. I think that if you have lots of attacks that debilitate you, and lots could just mean 1 a week. If it puts you out and it's pretty bad, and you are just done for the day before the day's even started, you probably, and our acute treatments don't work to get you out of it, you probably do need a preventative. And if you've got, I know there's this kind of funny line of 8 headache days, which your GP might say to you. If you've got debilitating headaches, we should be thinking about a preventative. We can't just be acutely treating it when it's there. And I've listed a number of preventatives out there. The one in red is not Pharmac or MedSafe approved, and most GPs and even neurologists would be a bit uncomfortable about using. The ones in yellow are the ones you kind of have to pay for, and I've mentioned a few of those already, or you may need to see a physician to do. Professor Goseby mentioned about neuromodulation, and I thought I'd just take this time to just talk a little bit about them. He mentioned about this one that you put on your arm, known as the remote electrical neurostimulation, and there have been other ones that are available. The ones on the left-hand side are actually available to purchase. The Kefli is a funny one. You can get it into the country, It isn't WAND approved. WAND's a special kind of, is the equivalent, is MedSafe for devices, not pharmaceuticals. But yet we can still get into the country. And it is a neurostimulator and has got evidence for acute and preventative treatment as well. The one down below it is called the gamma core, which is an external vagal nerve stimulator. The evidence for that is probably better in cluster headache, but it is available. It's just very costly, and there are the physicians who I'll mention at the end of the talk would probably be the ones that would have the most experience with it and would know the most about whether that's a option moving forward. Unfortunately, none of the options for neuromodulation are funded, and none of them generally are covered by insurance companies unless you've got like the highest level of insurance cover that I'm aware of. The one on the bottom right is the TMS device, which is a transcranial magnetic stimulator, which is almost impossible, as far as I can tell these days, impossible to attain now. But it's another example of me showing you that there are different ways that we can modulate the system in terms of which are not pharmacological, that can not only manage the attack at the time, but also prevent attacks in the future. And it's just to say it's not just all drugs. And I put this in there because unlike recently with the GPANTs, all our treatments have been one or another. It's acute treatment or preventative treatment. And neuromodulation kind of seemed to be able to do both, which was great but different, but a little bit fraught because of access. I do want to make a little mention about this bit. When we talk about treatments, there's always a little bit of caveat about evidence, and then similars or things that are similar. The ones on the right-hand side are a lot cheaper. It's a little bit harder to get the top one, but you can just go down to Farmers for the bottom one, or Rebel Sport that I saw the other day, and it costs probably a quarter of the price, even if the Kefli is on special. Don't ask me about how ethically you can put something on special, but they aren't exactly the same. Obviously, the Kefli can charge a lot more because they've done a clinical trial, and clinical trials are expensive. And the others haven't quite done that, and they can't be exactly the same because you've got to pay somebody for the right to to reproduce their product. Now, I'm not saying don't do it, because I appreciate that the Kefli being about $600 odd is expensive, and this one's like a quarter of the price. I would say that if you go ahead with it and it doesn't work for you, don't go, that's it. That's it for neuromodulation for me. There is no more hope in that direction. It should be, that doesn't work for me. Okay, there's some suggestion of evidence that that's probably a real thing. But if that becomes available again, and that's the work that has really been pushed by Migraine Foundation Aotearoa New Zealand, is that getting things funded and accessible. If it becomes accessible, it's probably worth another shot. This is just a slide to let you know about whether or not you can purchase certain things and how accessible it is to you, and whether or not it's funded. We've already had a brief mention about onabotulinum toxin type A by preempt protocol, or Botox for migraine. I've just put the number of injections out there. For some people, this is not for you. The number of injections just sounds terrifying, and I appreciate that. It is 31 injections, and I just mention it out there so you know. And I put in the images so you know whereabouts as well. Because if it just doesn't sound right to you, and you just don't like the idea of it, don't. And that's okay, because we should be thinking about other options as your physician. For others, this sounds great. You might get some side effects that you do want, but it's generally pretty well tolerated. apart from obviously injections themselves. But unfortunately, it is only hospital funded at the moment. And I can tell you it is very, very hard to have Botox funded, let alone to be seen in hospital for headaches. Very hard to get this funded in hospital, just because it's not just, here's a drug, it's someone's got to inject you, but that person needs to know what they're doing as well, which means and you've got to go into a room as well to get it done, because you don't want every man and his dog watching you get the injections done. We've had a lot of talk about the monoclonal antibodies, of which there are 4 and only really 2 available in New Zealand. 3 are actually MedSafe approved. I'm just going to focus on those, the 2 that are available. I do apologise if the pricing is not current, but this, I would tend to talk about one over another, just because of the cost of it. I appreciate it is a bit prohibitive, and at the moment, as you are aware, there are work to get the funding for it through Pharmac. And briefly, again, through the good work of Migraine Foundation, Aotearoa New Zealand, we know about things before on the website, before they formally come up and tell us about it, and that comes in with a atogepant, which has now become available, and we've already heard about that already. Here's a quick slide so that you can see availability of certain medications. And believe you me, trying to get pharmaceutical companies to come into a relatively small market is hard, but it is active work that is being done so that we have a range of things, because we know that it's not a one-size-fits-all situation. Okay, access. So in 2015, a colleague of mine worked out what would be the demand of neurologists around the country, and it should be about 74 full-time equivalents. So that's a whole person working 9 to 5, if you will, 5 days a week. And we need 74 of them. In 2022, we only had 36. I've just been informed yesterday that that's improved. It's not been published yet, but I believe we're about almost 60 full-time equivalents, over 70-something or other neurologists at the moment. In 2022, the number of headache or concussion interested physicians have remained, unfortunately, the same to today. Auckland's a little bit luckier with having more people up there, but then you have more people. That's why you've got traffic. Whoops. I'm based down in Palmerston North. So up in Auckland, there's Kerry Brickwell, Rosamond Hill, whose name is probably quite familiar to a number of you, and Dr. Ray Bose, who I had the pleasure of working with. In Wellington, there's Heidi Pridmore, and in Nelson, although she goes up to Wellington to do her clinics occasionally, is Dr. Desiree Fernandez. So what can you do in terms of helping? I'm sorry to put this back onto you, but the headache diaries, again, stress is so important. It's really important to help us work out. It helps us track things. It helps your GP track things, and when they go, I don't know what to do next, we can look at it. So what would I want to know? Well, actually, I want to know a lot. I want to know as much as I possibly can. And you've seen before and you've heard before about how there's a number of oral preventatives. When I choose an oral preventative, I'm not going to just go, take this, see me in a couple of weeks, couple of things. We don't have the ability to say, because of your experience, this is the one for you. This headache experience, this migraine experience of yours, this is the best one. It's the best one for everyone. Go with this first. We actually can't do that. We have no ability to do that. When we choose a preventive, we choose it based upon what side effects we want to avoid, what side effects we might want. What other comorbidities you have that means that that's not a good idea and that's maybe a slightly better idea. That's how we really choose it. I guess with the more modern ones, which your GPs may not be as comfortable doing, that's a little bit different in terms of side effect profile. But we don't have the ability. So this is the bare minimum. But the headache neurologists that you will see want to know as much as we possibly can about you, because I'm hoping that the translational work that Professor Goadsby is doing and other headache neurologists are doing, they're going to want to know that, because maybe we will be able to find that thing that predicts that this is more likely to work than another. But I kind of want to know how often do you have a headache, and how often they're really bad, and what type of pain relief you're taking, and how often you're taking them. Because that at least gives me a little bit of an idea of your burden as a starting point. And then what has happened with the medications? Did they affect your burden? I hope we can do more, and that the slightly bleak management availability that we have in using does improve. And I want to thank again the amazing work that's been done by the Neurological Foundation and the Migraine Foundation Aotearoa New Zealand in terms of supporting you as patients and us as clinicians.